Good afternoon. My name is Dr. Priya Sharmaganathan. I'm a anaesthesiologist in Dunedin Hospital in New Zealand, and with me is Associate Professor Kristen Schreiber. Hi.
Hi, yeah, so I'm Kristen Schreiber. I'm an anesthesiologist, predominantly working in regional anesthesia, but doing research in the acute to chronic pain transition, so that's what I'm going to be talking about.
So we've heard you talk today about psychosocial modulators, and I guess the presence in chronic pain, chronic post-surgical pain. I was wondering if you could give me your thoughts around how we would identify these patients in our pre-assessment clinic. Where do we go to in our pre-assessment clinic for these sorts of things?
Yeah, no, that's a great question. So I've done most of this in the context of a research study, but I have the privilege to work with a PhD psychologist who's really good at measuring psychosocial factors themselves, right, with brief validated questionnaires. So we've actually employed those in a really easy to sort of click on link where it takes the patient to a form to fill out, and so we can measure things like anxiety, depression, catastrophizing, somatization, all of these sort of psychosocial factors that we think probably play an important role in increasing the risk of making that transition to chronic post-surgical pain. So, I mean, I know that there are definitely places like Stanford has this choir system where everyone who comes into the pain clinic, for example, does this. And I know at Duke, they've been kind of systematically doing this with a lot of their patients in the pre-op clinic. Just sort of, as soon as you come in the door, you fill out a bunch of surveys, and they're not particularly long.
And so if there was one, psychosocial factor in particular that you had to choose, what would that be?
Yeah, no, it's interesting because empirically, when we look at what's the most robust predictor of chronic pain 1 year after breast cancer surgery, for example, it was actually baseline sleep disturbance. So I wouldn't have necessarily thought that that was going to be the one, but it seems to be the most consistent. Another one that is pretty interesting, and a lot of people talk about it, is pain catastrophizing. So the tendency to ruminate, magnify, and feel helpless in pain. And there's like a brief questionnaire called the pain catastrophizing scale. So, each of those would take about, a minute or something.
Do you have any thoughts on the patients who come to us and say, I've got a very high pain threshold? Does that ring any alarm bells at all, or not really?
Yeah, that's really interesting that you say it could ring alarm bells because I think sometimes people do actually know that they have a high pain threshold, and other people are trying to really just validate that they do have pain, and they're like, look, believe me, I have pain. I have a high pain threshold. We've actually done a set of brief bedside quantitative sensory tests where we apply like a distinct painful stimulus and ask people to rate that, right? So we're actually objectively measuring what is your pain threshold, for example. And the interesting thing is that when people tell us, oh, I have a high pain threshold, they don't necessarily. So we have objective data about whether or not. I don't think it's necessarily a red flag, though. Yeah.
So today we've been learning a lot about how prehab is best delivered in a multimodal fashion. For these patients that we might identify as being prone to persistent post-surgical pain, is there sort of a psychological prehab that they could undergo?
Yeah, no, that's a great question, and I think we don't have the answer yet. I know there are some really great studies going on with preoperative, like sort of mini CBT course or ACT, acceptance and commitment therapy. Some of my colleagues at Brigham and Women's are doing those now, and many other people have been starting to look at that. I think it's tricky because every given individual has a number of different risk factors. So like, let's say they have high pain catastrophizing. Do you want to go after that with cognitive behavioral therapy? What if they also have sleep disturbance? Do you want to go after that? And so I kind of like the idea of a multimodal or a multi-potent intervention like exercise, which may impact your mood, it may impact your sleep, and probably also has cardiovascular benefits as well. So I think I like the idea that a lot of people are starting to look at prehabilitation, like physical prehabilitation, that it might actually impact the psychosocial factors as well.
Yeah,
So-
seems like exercise is the magic bullet when it comes to
Yeah.
our health. And I guess lastly, what's the role of regional anesthesia in kind of persistent post-surgical pain?
Yeah. So I mean, I'm a regional anesthesiologist, and I chose that on purpose because I think it's probably the best tool for sort of shutting down that pain message right at the time of surgery. But the studies that have looked at whether it can truly prevent chronic post-surgical pain are a little bit disappointing. And I think part of it is that most of the people who are in those trials actually don't develop the outcome. So almost all of the studies are underpowered. So something we've been trying to do is say, okay, amongst a group of very high-risk people, if you compare people who got a block and didn't get a block, do you see a difference? And in fact, we do see that. So in a way, it's like, don't throw the baby out with the bathwater, you know, and just figure out which of your patients really needs regional anesthesia if you're resource limited. That being said, you know, it improves acute pain for most people and reduces the amount of pain meds that they need. So,
Yeah,
I mean, I think it's definitely worth doing.
yeah.
So,
Well, thank you so much for your
Yeah,
time this
no,
afternoon.
thank you. Thanks for the interest.
And it's been an absolute privilege having you at our ASM.
okay.
Thank you so
thanks.
much.
Thanks.